Hello everyone, Kent Bresler here. I want to welcome you to Kent's Kidney Stories. During our time together over these podcasts, I'd like to discuss kidney disease. I'd like to tell you about my journey as a transplant patient, but also talk about dialysis, kidney donation, and just about anything else that might be of interest. Kent's Kidney Stories, podcast endorsed and sponsored by kidneysolutions.org.
Hello, everyone. This is Kent Bresler. We're going to do some podcasting today. I've got a really great guest. I call him a high flyer. This is a gentleman that I'm looking very forward to talking to, and I know you're going to enjoy it also. Let's start with prayer this morning. Lord, in moments of confusion and doubt, grant us inner guidance and peace. Help us listen to our hearts and follow the whispers of your divine presence within us. Silence the noise of the world so that we may clearly hear your voice, leading us towards the right choices and actions. Thank you for being a constant source of wisdom and comfort and peace. We ask all of this in your name. Amen. Okay, folks, this is the fourth in a series of podcasts that I've had the joy of doing with Natera. We have discussed one of their successful lab tests for rejection called Prospera in these podcasts. But today we have a special guest, Dr. Matthew Cooper, who is the Chief of Transplantation, Director of Solid Organ Transplant, and a Professor of Surgery at the Medical College of Wisconsin. He is the Mark B. Adams Distinguished Professor of Surgery. Dr. Cooper seeks new opportunities for living donation through innovation and by removing disincentives for those considered donating while promoting the safety and the long-term care of living organ donors. His clinical interests include kidney and pancreas transplantation in both children and adults, particularly the use of marginal organs, and he has chaired several national task forces which have led to many innovative projects to potentially bring more patients an opportunity to receive this wonderful gift of life. Dr. Cooper is involved in several ongoing clinical research projects, primarily with an interest in immunosuppressive minimization and intolerance and avoidance of delayed graft function in kidney allografts following preservation injury. He has authored over 260 peer-reviewed manuscripts, 300 abstracts, and 12 book chapters. And he is regularly invited to speak out and on a variety of transplant-related topics, both nationally and internationally. It's a pleasure today to welcome Dr. Cooper. Good morning.
Hi, Ken. Thanks for having me. It's great to be here.
Okay, so there's a really keen interest in the kidney community, kidney world about, especially for early identification and for testing for rejection. All right, in my case, I have never had a rejection episode, so I can't experience it, but I have several friends who have. But my one main issue during my whole course of 37 years with a donated kidney, my brother's, I've always had the fear of having to get a biopsy. I had one initially for diagnosis, but I've never had one since in the 37 years I've had my brother's kidney. So today, part of this whole process is talking about, doing really taking a look at the proactive study that you're involved in. And so we're going to be talking about cell-free DNA levels and how they really work with patients. We're going to focus on that if we possibly can in the study, and then how easy it is for this study to occur, but that it is available, and hopefully at some point in time maybe we won't have to do so many biopsies. So, what does monitoring rejection really mean, and what does cell-free DNA have to do with that?
Yeah, thanks, Ken. I very much appreciate the way that you introduced the beginning of our talk here. The challenge for patients is, number one, receiving the gift of life. And then what we try to avoid is an ongoing fear of what could happen afterwards. And I appreciate that there's there's always a concern of, could rejection happen to me? And the challenge that we as practitioners who also share that is, sure, we have some experience and we have, some pieces of information that have informed us based upon past experience about who has maybe a higher risk. But I mean, we don't have a crystal ball. And at times, although I wish we did, we have to try and continue to think of better ways to both put our patients at ease and to ensure, I always like to say that we are, and this study is perfectly named because I do this all the time, to say that we're proactive rather than reactive. Because the challenge with transplantation with the immune system, at least, before we had the availability of cell-free DNA with, the companies like Natera, was we were reliant on the use of, I think, an ineffective biomarker. And serum creatinine, it was that marker. And everybody knows, if you're any part of the healthcare system or if you've been a patient and you get blood drawn, that one of those tests is creatinine, which is quite honestly an indirect measure of how your kidneys are function. It's the breakdown product of muscle, and based upon your age and your size and your sex, people have different creatinines. But it is a really lagging indicator for kidney health. For us, like I said, we always want to try and be on top of things as much as possible and be as forward thinking as possible. But creatinine really never gave us the ability to do that. And there's been a lot of data, and some of this started with your comment on biopsies. There were many of us, folks could see me, the gray hair. The more gray hair you had, the more you had an experience of doing biopsies on a protocol basis, because you thought at that time, that was your gold standard. And in order for us to be as forward thinking and as progressive as we thought we should be, we would do biopsies at 1 month, 3 months, 6 months, and a year. And particularly for, programs that I've had the pleasure of working with, where most people would consider the recipients either high risk or the organs that we were, able to transplant. One of those would be high risk, and sometimes both. But biopsies, if programs have never had a complication from a biopsy, they've probably not done enough of them, because there's always a risk associated with a biopsy.
Exactly.
And I don't want to scare the public, right? But let's appreciate the fact that this is a procedure, right? We consent to this procedure, and we're putting a needle into a otherwise what we hope to see is a healthy kidney. But there's a risk of bleeding. There's a risk that could require a surgery if the bleeding is extensive. There's even a risk of infection. The risk that the biopsy specimen is unable to be interpretable and then requires a second biopsy. And all that is to say is it was a huge patient dissatisfier. It's important for us to ensure that we are still utilizing the gold standard when it's necessary. But we were never, I used to say, smart consumers of biopsies. We would just do them all the time because either we thought we needed them to be on a protocol schedule, or anytime we saw a change in creatinine, which, let's be honest, your creatinine can change for all different reasons, the simplest of which is you can be dehydrated.
Mm-hmm.
And we don't want to be biopsying a kidney with all its risks if we can find a better test that's going to allow us to be sort of smarter, when we are going to decide that a biopsy is necessary. And that's exactly where, we find ourselves now with cell-free DNA. It is I think, a more sensitive marker for kidney health and or kidney injury. And it allows us as practitioners to then determine if and when a biopsy might be necessary. And I'll say from personal experience, and been an early adapter and something I'm very proud to say, my need for biopsy dropped significantly, when I started to use cell-free DNA in our post-transplant clinic and in the monitoring of our patients. And to me, I think that's revolutionary. And it probably hasn't been celebrated enough, quite frankly, how that's changed our practice.
I don't think it has been celebrated enough. And I can tell you from a patient standpoint, the fear of biopsy, okay, is just one part of it. But when you find out you can have a blood test that can monitor you, I mean, that's significant. And I think it is going to be, I don't know, accepted much more readily. And I'm glad to hear you say that you're pretty much a believer in the test itself.
It didn't take much to convince me, Kent, because I always also believe that as a committed transplant physician, we have to constantly think about how we can do better. I say, and I'm honest in my thinking, that until we have the assurance of an organ for everyone, and then there's one patient for one lifetime, that we have to consistently think, is there a better way of doing things? And when I started to see the data that was available on cell-free DNA, and again, recognizing my own struggles, as I said before, with the use of biopsies, which were very difficult to set up. They were challenging for patients, and I was worried every time we did one that this was an opportunity for us to look at how we would monitor patients better. What we should make sure also the public knows is what is perhaps even a greater value to the use of cell-free DNA is not only in its ability, and we can talk more specifically about the proactive study, and its ability to predict the future, but also in its ability to say that everything's fine. Because sometimes that isn't, I think, either easily predictable or something with which, we are talking enough about either. So for instance, the longer that a patient is out from their transplant, the risk of rejection may be different, but it never quite goes away. But at the same time, our consistency and the regularity with which transplant centers and patients meet, have data, and even have conversation becomes less and less. And so in my mind, the time with which we ask a patient to get data, to get their blood drawn, I'd rather have a test that says, from a more sensitive standpoint, that everything was fine. We call that the negative predictive value. I mean, your cell-free DNA is normal, your creatinine is normal. We should both be confident that everything looks terrific. And so there's both an opportunity to allow cell-free DNA to be our discriminator for, do we need more information? In other words, do we need a biopsy? But it's also very important for us to say, we haven't had a lab drawn, for instance, maybe since 3 months ago, but the cell-free DNA is normal. And I can be comfortable, and I should be able to make sure that my patient is comfortable that everything is fine. And that's important, right? Because we want people to be celebrating being a transplant recipient, not constantly worrying
exactly
what's going to happen next, right? So that part to me is, again, sometimes forgotten because we become so fixated on short-term outcomes, but our patients want to know 10 years, 15, 20 years from now, like yourself. And I feel more comfortable in the monitoring of those patients. And again, we can talk about how expanding this to our referring nephrologists in the community so that this can happen, that utilizing cell-free DNA is critical, I think, to be able to give patients the rightful peace of mind that they deserve after receiving the gift of life.
Okay, so let's fold in this study. Give me a little short background on the study in itself, and then how it applies to the general kidney population. What does it tell us?
Yeah, so this is I always worry sometimes that the word study gets mistaken or gets improperly defined. So this was a retrospective real life registry. In other words, we asked transplant programs who were utilizing Prospera to share their data into a national registry with which Natera collected and then allowed us to analyze the data and determine results. And so multiple transplant programs from around the country, multiple principal investigators who, again, like myself, were committed to the use of cell-free DNA, participated in this registry in adding patients' data to the database. And then with the help and support of Natera and with some smarter people than I can, the biostatisticians and our scientists who help us, make sense of a lot of data, we looked at both patients who had cell-free DNA, at least greater than one, so 2 or greater cell-free DNA tests, and a biopsy. And again, this wasn't a prescriptive study. In other words, it wasn't, you need to get so many tests during certain days and you must do a biopsy for X, Y, and Z. This was, tell us your real world experience. How are you using the study? And then we sort of took all that backwards and said what we could interpret from the real world data that our investigators put into it. And so if they had cell-free DNA and they had a biopsy, we were able to look back prior to the biopsy with the cell-free DNA information and say, could that have predicted what we eventually saw under the microscope? In other words, was it a leading indicator for what ultimately the gold standard told us? And essentially, with that data, of approximately 425 patients or so who had, like I said, both the biopsy and the cell-free DNA, that we were able, in sometimes, almost 5 months in advance, based upon what the cell-free DNA was telling us, predict what we were going to find under the microscope, all with a normal creatinine. So if your kidney function that we had always sort of held up as the way in which we monitor patients remained normal, and so most of us, because there was no other thing we could do besides doing all these routine biopsies, which wasn't safe either, we would have typically done nothing. If the cell-free DNA began to tell us there was something wrong, we could now intercede because we now have this Prospera registry, which says, listen, the biopsy is going to eventually turn into a problem. And so utilizing the Prospera registry data, it allows us, I think, the confidence in demonstrating the value of integrating this into your clinical practice. So better than just checking creatinine, certainly better than just sort of expecting patients to have a clinical symptom, because we know rejection doesn't come along with symptoms. We're now adding a more sensitive test that says, okay, the Prospera percentage, or now the absolute value current day, is changing, the change between one to the other. Our program should be should follow this patient closer, or maybe it's time to get a biopsy earlier, because a lot of times, what we would find is that the signs of early rejection could be identified on a biopsy that was deemed necessary from your cell-free DNA. And we all know the earlier that we can intercede, the better the chance we have of preventing perhaps an early rejection from becoming a really significant problem. And so bottom line, that's really what this real world data told us, was that cell-free DNA was predictive of biopsy proven rejection, both antibody and cellular rejection. And so encouraging programs to use it as a surveillance, as concerns for a high risk population, because it is more sensitive and it provides significant value to the long-term success for your patient.
So this is early detection in its best. And I think that's the most important thing that people should take away from this. And it's a Bromberger et al., a lot of people involved in this particular study, if you will, or paper. This is going to be published pretty soon. And so we're getting preemptively a look at this results. The elevations in your cell-free DNA, I know there's normals for everything, like, your creatinine levels in, zero point 0.2 to 1.4, depending where you're labbed. What is a normal range for cell-free DNA?
It's a great question, Ken. So again, it's a percentage of overall. So when you hear a number, that's the percentage. And so normal, and I'll put a couple caveats after giving the answer to this. So normal is 1%, below which we say patients are in a good place. Above is where we get more nervous. Now, the caveats. I believe that every patient is a little bit different, as you've described.
Oh, sure.
And so having a kind of line for patients is critically important, because what also I think the future studies have demonstrated is that the change from one value to the last. So if I, for instance, was a transplant recipient and I had a cell-free DNA level of 0.3, which would be considered, quote, normal. But at month 2, I had another cell-free DNA, and now it's 0.7. So still, quote, under that 1%, but my change now has gone from 0.3 to 0.7. So it's more than doubled. I think the folks from Natera were leading in the appreciation that the relative change between one to the other is also a signal of activation, that the immune system is responding in some way to result in an increase in cell-free DNA in the recipient's blood. So, and this was something that I learned from experience as well, was that meant for me that I needed to look more closely at this particular patient. And oftentimes that would be the patient that I would choose to do a biopsy on. So even though the threshold may not have been crossed, the change in the relative value for me meant that, and this is all the assumption that we have a no change in creatinine, that we should look at this kidney as with the best information we have available, which is the biopsy.
Yeah.
So we still, and Natera has been, I think, very honest in saying as well that, this doesn't eliminate biopsies altogether. We still have a need for biopsies. It just is, let's be certain that when we're doing a procedure, we have the best data to direct us to say, yes, this procedure is necessary.
Yeah, it's not a serial thing. It's more of an observational one that you have data to support. If it's elevated, and I guess you could use the example of the PSA for cancer of the prostate. A lot of docs say, it's not worried about the trivial. It's going to go up as you age, but also if it does a gigantic spike, then you get big problems, and that's where you want to be really careful. So you monitor to follow, not for investigation, but actually to help the patient get along day by day, not once every year.
And I'd add, that's right, Ken. And what I would add to it as what I believe also is then the expectation is if I are believers in the value that cell-free DNA provides for me as a clinician and for my patients, then we can't ignore what the data tells us either. So in other words, the Prospera study said, if there was a significant elevation in your cell-free DNA, there was a biopsy that demonstrated that down the line, something was troubling your patient's transplant, rejection.
Mm-hmm.
So if we as practitioners are going to employ the use of cell-free DNA, and we see that signal, it means that we have to act upon it now. Right. And so what I would advise is that let's not just complicate the already complicated routine of a post-transplant patient by adding additional tests, but let's make sure that we use the data that's in front of us and be, like I said, smart consumers of biopsy when necessary. If there's slight elevations that perhaps the investigator, the clinician doesn't feel warrants aggressive treatment, then at a minimum, closer follow-up and maybe another cell-free DNA a couple weeks from now, rather than saying, well, it's elevated, let's just wait another 6 months.
Yeah.
To me, that sort of misses the purpose. Like, let's use the test properly. And if used properly, the Prospera registry says that it is a leading indicator of rejection down the line. So let's let the test help us and not just ignore what the data is intended to provide.
Have you set up in your clinical practice? Now we're talking about not the world, we're talking yours. Do you have parameters? Do you have set up some type of protocol for actually doing the testing? Is there okay, we want to do this every 2 weeks, we want to do it every month, we can get away with every 6 months? What's kind of like your rule of thumb, or have you started looking at protocols for doing the testing in itself?
Yeah, I again appreciate the question, Kent, and again, to be honest, I'm directing a newer program. I've been on site here in Milwaukee now for a year. Boy, it's hard to believe it's been a year, but I've been here a year, so I can talk about two experiences. So at my previous place of employment, we had a very robust program and protocol that we would employ for all patients. And why is that important? For two reasons. One, like I said, I wish I could be able to say with absolute certainty who has an immune risk and who doesn't, meaning who has no chance of rejection and who possibly does. I've given up, my ability to predict the ponies a long time ago. So I know,
No.
I think everybody deserves the right to have that tool available to them. So for everybody, we would have on a like I said, a protocol basis. So they would get their cell-free DNA. We eventually moved to 4 times a year. When we first were part of the learning curve, the frequency was much more in the first year, but we essentially settled into a place where we think having something done every quarter, assuming normalcy, and we would do that for the entirety of the transplant patient's time with us. The challenge is right now, CMS has sort of thrown a little bit of a wrench in things and is making it difficult for me as a clinician to say, I want to do this on a regular basis. I want to just, without clear indication, use this for, as I described, say 4 times in the first year as a surveillance. What currently is the expected place for the use of this test is in place of a biopsy. So the clinician needs to have some reason for wanting to do the test. Natera has been a terrific partner for us in helping us to work our way through this. And so I'll simply say we are in the process of creating our regular draws of patients, our regular evaluations of cell-free DNA in our patient population, because like I say, without having the ability to identify a problem before there's a problem, I think we're both missing the value of the test and we're doing an injustice to our patients. So the answer was, I believe in it. My past experience was to use it on a regular basis, both for cause and for surveillance. And my future is I would like to be able to have it performed on all of our patients on a regular basis, because I think that's the best way to provide safe, cooperative, and quite frankly, resource sensitive patient care. In other words, do a biopsy when you need it, but make sure that you are taking care of your patient first with the best data that's available.
I think that's the safety aspect of this whole thing. Biopsies in themselves they're not only difficult to do, but there's a good risk that things could go wrong. That being said, they have to be done. There's no reason in the world not to do a biopsy. This is not going to replace it at this point. There's got to be much more study involved in this. And that's what I think is beneficial for the population. No, don't expect this to take us, the place of a biopsy. Just realize that if you're, have a chance to have these tests, it's something that you really should consider. It's something that should be recommended by your nephrologist or whoever is practicing or working with you. So, yeah, I don't see any problem with the continued use of it. And then this monitoring of it is even more important. Show it's effective, like this particular study did. Show that it is effective and it's worthwhile. All right. And it's a good add-on to anything that we have now. At least we're looking outside the box and working our way down the road. We're not sitting still and just vacillating. So yeah, I like this whole concept, and we know we need to be doing more. You mentioned CMS, and also insurance has gotten into this now too, where they're not going to be paying for it. And that's tragic. In some ways, it could be very difficult for anyone to get this, let alone, the general population, even if you have insurance.
Yeah, we're we're now we're going to get my ire up, Kent.
I
We
know
don't want
I got you whacked
never
because
want
I'm
insure.
whacked about it. Yeah. I don't
We just don't.
I
You
really
don't want
feel
insurance
that.
companies to ever determine patient doctor conversations, discussions, planning, right? You never want that. But what's particularly troubling is when you have data that demonstrates you not only provide better patient care, but in the long run, it's cost savings. In
Yes.
the long run, it's cost savings. I'll say that again, because again, biopsies are not only have some risk associated with them, but they're expensive. They require a procedure. They require the use of, for most of us, ultrasound. So there's a radiology fee, and then there's a pathology fee. And this all is done in a hospital or done in a clinic. And so
Okay.
there's facility expenses as well. So being able to avoid those expenses, and this is, boy, I'm not the person to talk about, whether you place cost over patient care, but there is a cost savings, but it's better for patient care. And insurance companies that, again, are, I think, not recognizing where this test is now and how ultimately it will save healthcare dollars,
Hmm.
consumer dollars, is just so short-sighted. Because, like I say, the cost of biopsy is one thing, but then the cost of treating rejection is another huge thing. The admissions to hospitals, and so all of those things, if we can avoid those costs with a blood test, boy, I mean that.
Makes
I'm a
sense.
simple surgeon with simple math, right? I mean,
Yeah,
to
exactly.
me, it seems like that's an easier choice to make.
Yeah, and in that light, given the chance to increase the value of a patient's visit, all right, patients don't walk into a doctor's office for anything but advice and counseling and guidance. As a kidney patient, I can tell you when I go see my nephrologist, after he's done everything that he's done for me so far, he's still got options. And he's got to convey those options to you. This is just another option afforded to the population. This option is by far meaningful and well thought out. And now we just need to be able to use it. There shouldn't be any barriers to it. Right? Really shouldn't. So
Well,
there's not a way that I can see in my mind that this is available to everybody. But Natera is really trying to make this test available. Are they not?
no, there's no question, Ken. I'll back up and say one thing. Patient voice is incredibly important. So when given the opportunity or the desire to take opportunity to one's hands, you'll make sure CMS knows what you're thinking. Make sure your representatives know what you're thinking. Whether I hate to think that things have to become a political battle, but sometimes they do. But let's never minimize the patient voice and what patients want, and that relationship between patient and caregiver should always surpass insurance companies. That's just one thing. And then the second thing to answer your question is, Tara, like I said, has been very supportive of me personally, and I think of the national transplant enterprise in really trying to provide programs and clinicians with an experience, because you need to get an experience with it. You need to have your own examples of how it's improved your ability to deliver care, or your ability to improve a patient's quality of life, or overall their survival of their transplant. And most people, I'm the unapologetic optimist, but I believe, that most people, when they get that experience, they'll realize that it's a value add to their clinic. Particularly as we're working, meaning Natera and the electronic medical records are working to try and seamlessly integrate so that we can be able to utilize the electronic ordering system and make sure that information comes back into the EMR. That's a piece that Natera has been, very much invested in. I think the support of the company to be able to give people that experience, to give them, the Prospera registry, and to put it in their hand and say, listen, this is what it can do for you and for your patients, and really just giving people the information that they need, to be able to make an informed decision. I believe we're going to have a greater acceptance and greater utilization for transplant patients across the country.
I agree totally. I just, throughout the years, it's always been my opinion, and this is, since the podcast is, Kent's Kidney Stories, my story is very simple. I want options. I don't need direction other than options. Give them to me, how bad they may be, or how good they may be, but give them options, and then let me make the decision, okay, that this is what we want. And if I would like to be in a program like this, where I can get, cell-free DNA testing, all right, I need access to that. I want that access, and I want others to. Everybody should be affordable to everybody. So how does that come about?
Again, I think you folks like yourself who continue to literally broadcast the message.
Okay.
And when CMS, they have regular periods where decisions that are planned to be made, there's a public comment period where anybody can give their opinion about what is a planned change, whether it's good or bad. I would tell people to make sure that they take advantage of those experiences. I think there was a lot of patient organizations. I think the National Kidney Foundation, for one, has been very forward thinking and supportive of this as well. I think is our advocate. But I think in general, from an individual patient's perspective, ask the question of your transplant program, whether you're pre-transplant or post-transplant. Ask them about their availability of Prospera, and why or why not are they using this test. Because sometimes it does take a patient to come into the clinic and say, I've read this information about cell-free DNA, and it's compelling, and would just like to get your thoughts around why the program either is not using this, or perhaps we as a patient provider partner team might think about utilizing it for the care of my transplant.
Yeah,
you have every right.
I agree totally.
This is your health.
Yeah,
it's your health, your kidney. We don't. It's not my kidney. It's not my transplant program's kidney. It was my ability to be able to participate in the sharing of the gift of life from a donor to recipient. But now it's your kidney. And like you said, your desire to take care of it is all I ask. And if we together believe that there's a way that we can care for that transplant better, let's give it a try. So speak up and make your wishes known.
Okay, well taken, and because that's exactly what we're doing. AAKP and Kidney Solutions, that there's an effort to try to get this information out and do it quickly and as efficiently as possible. I was trying to, when you get access out to patients in the clinic setting, all right, there's a program, nephrologists are afforded the opportunity that we have general nephrologists, but we also have some very highly technically transplant nephrologists that work closely within the organization at NephCure to talk about things like this. Can you shed a little light on that program or how that's used?
So what we have the opportunity to celebrate, Kent, is the average survival for a deceased donor transplant is approximately 14 or 15 years. Living donors, 20 some years. Your example, one that we again should celebrate. But what we have to recognize is, as a transplant center like myself, hopefully we continue to bring more people to listing, more people to transplant, and our ability to be able to follow those thousands of patients 10, 15, 20 years following their transplant date is just, it's just darn near impossible. It's not something that, if we could do it, if we had unlimited resources, we would certainly do that. And we are always responsive to the donor and to the recipient following transplant. But there is just a wealth of opportunity in the nephrology community outside of transplant programs that continue to provide post-transplant care for patients after their transplant. And there's no rule or law that says Prospera can only be ordered by someone who works in a transplant program. It is a test that's available to the community at large. And we encourage that ongoing dialogue and partnership with the referring nephrology community, so that after patients are transitioned or are partly transitions back to their community nephrologist, those nephrologists could order the cell-free DNA as well.
Yeah.
And either, based upon the results, decide if there's an intervention that's necessary. If based upon the results, they would wish to contact us and say, our patient, because it's always an hour, our patient, we drew a cell-free DNA and it appears elevated. Can we talk more about that? Or, they can simply, have the patient's results sent back to our program and we can interpret it all. There's all sorts of options available. What we're saying is it's better to have more eyes on our patients.
Absolutely.
And more participants in the care of folks post-transplant. And cell-free DNA can be ordered by any of those components to make sure that we are, again, utilizing the most sensitive and the best information to be as proactive. Let's throw it out there again, as proactive rather than being reactive when we see a significant change in one's creatinine, which is, let's be honest, it ends up now being a little too late if we have a test that could have let us know earlier.
Yeah, and this is the test. Believe me, we've been watching it. I believe that these tests are valuable and they need to be in the clinician's hand, and they need to be allocated for. All right, it's going to have to happen. Somebody's going to, in our system, it's pay, and there's got to be a payment source. So we won't go down that bunny trail, but I do know that all of this study that's coming out, this Bromberg study, as it is, it'll be out soon. It's going to be published, and I encourage everybody to start looking for it. When that comes out, it's going to be major. I think it's going to be focused, and it's going to help the community, the clinical and the kidney community. So we're looking forward to that. Give me off the top of your head right now where you see this all going. We've discussed it. We've talked about it. And where are we going with it? Where do we need to go? All right. You're driving. So
yeah,
where do we need to go?
I can be king for a day, Ken. I get to be king for a day.
Yep. Now you're
yes.
in charge. You're driving.
Yeah. Well, again, so in my mind, we have to provide holistic care for our patients. In transplant, I mean, to be honest, we've only focused on short-term outcomes. They're important. There's no question. Short-term outcomes and quality short-term outcomes affect long-term survival and quality of life. So we never should sacrifice those. But we need to focus on the long-term and the overall survival benefit of transplant, which includes avoiding issues which we know will affect all of those downstream things. So in my mind, we should be adding cell-free DNA to the regular maintenance follow-up of our transplant patients so that we can both provide identification of kidney injury and, my choice of words, course correct or decide that we need even more sensitive test, and in other words, a biopsy, to be able to define what that problem might be. And we should also be able to use the test to ensure that what we believe and what we're telling our patient, that their kidney function and their overall expectation for long-term kidney health is good, is now supported by data. So I think, again, if we were to incorporate this, at a minimum 4 or 5 times, in the first year, so early when the immune system is more challenging and more activated with a new kidney in place. And then afterwards, whether it's, every quarter or at a minimum twice a year following transplant, we should be making sure that cell-free DNA is part of the care of all patients forever and ever. Amen. Because again, in my mind, it's very short-sighted to focus on the fact that we have a 1-year or a 3-year graft survival. We have a biopsy proven acute to rejection rate of such and such within the first year. What I'm going to start to be able to talk about is, let's frame shift where every program starts to know what their 10-year graft survival is, what their 15-year, what their 20-year graft survival is, and be able to correlate that with early events or with events along the way that, had we had either more closer follow-up in conjunction with maybe our community nephrologists that we just talked about, both of which we're utilizing cell-free DNA, that we're able to achieve better outcomes, maybe we'll be able to put the story together a little bit better. That this investment, as I said, has to be, a holistic investment in the transplant patient, a holistic investment in the living or deceased donor. And we need to provide the best and the highest quality, the most sensitive data to be able to provide the long-term post-operative care that I just don't think we're doing enough. We weren't doing enough with creatinine alone. And cell-free DNA gives me sort of more, it makes me more comfortable that we're getting to a better place.
And I've been in this drive, if you will, this journey for over 50 years, right at 50 years now with FSGS. And my listeners know this, and a lot of my friends understand that you can't get anywhere unless you keep looking. You stop looking, you lose. So this is a tremendous thing for us to be looking at. And that's cell-free DNA and this testing, preemptively testing. And there's got to be a baseline driven, and it's got to be reimbursement for it. There's no doubt in my mind. So I asked everybody out there, let's get behind this testing, this cell-free testing, and make it go. Learn more about it. We'll have Dr. Cooper back. Maybe we'll have him on in our support group. And there's several things that we can do to get this out there. But the most important thing is you got to school yourself up. You got to bring yourself up to a level that allows you to understand the concept, right? You don't have to know the nuances. You just need to know what it is that it will do for you. Okay. It is better to have some testing up front than just to go straight to a biopsy at some point in time. Okay. This is a precursor, and it's a good vehicle. It's timed and proven, and that more time we have and the more testing that gets done, it'll prove itself. I really believe that.
Couldn't agree with you more, Ken. Ask questions. Make sure that you are getting what you believe is the best care that you deserve.
Absolutely. And you can't, if you understand this, if you've never had a test like Prospera, if you've never had it, what's wrong with when you go to your nephrologist next time is asking for it, or even your PCP if you go. It's not bad to say, hey, have you heard of Prospera? Have you heard of this cell-free DNA? It's okay. I've just read about it. I just listened to a podcast about it. I think it's in my best interest to have that particular test done. Can you make that happen for me, please? That's a request, and it's an honorable request, and it's one that you're afforded as a patient to be able to do. It's your right. All right. You're part of the program, and it's you. It's not about others. It's not about the next fellow. It's about you. Like Dr. Cooper said, it's your care. All right. So
Yeah, let me go on to say, Kent, that, and I hope listeners are appreciative of this. I never worry about patients asking questions. To me, that makes me comfortable in their recognition that the success of their transplant is their engagement and their interest and their participation. And it's not something that I can do alone. I certainly have tools and I have interest and I have enthusiasm and aspirate and all those things. But the formula for success, my opinion and my experience is, a willing patient who wants to participate in their care and ask questions. If you have questions, that means you're invested in this. And so I encourage people to ask questions. If I don't know the answer, I'll tell you. I'll go look for it. But for someone that asks questions, to me, that is, that's a demonstration that we're in a good place together because we are both thinking the same thing and we have a relationship where you feel comfortable to ask me the question that you deserve to ask.
Yeah. And then, you know what? Now I was saying that we're going to end here and then I'm going to send on this note, you have a transplant. Okay. That's an organ that was given to you out of pure love and loss, maybe. But here's the deal. That's not yours. It's the person who gave it to you. You're obligated to make every effort to take care of that organ, that kidney, that liver, whatever. It's your obligation because it's not yours. It's a borrowed item from someone who was respectful and loveful. So make sure that you everything that you possibly can to protect it, number one. And so get into the doctor, do the things that you're being asked to do, and understand what it is that's available out there to make it even better for you and that transplanted organ. Enough said. And so I'll just let you know that I really do appreciate you, Dr. Cooper, for coming in, and this has been eventful, and we're gonna go back and do this again. I guarantee you. All right.
Yeah, please, Mike. And anytime folks want to, the challenge isn't getting me to talk about transplant. It's usually getting me to stop talking. So anytime we can talk more,
we'll put
I'm ready.
into it. We'll put into it right here, but it's going to continue. So everybody, like I've said before, and I'll say again, keep breathing.